Onc Live Insights is a video editorial program produced by Onc Live.
So I think we're learning as we go as how we're going to combine the new target therapies with monoclonal antibodies against CD20. Of course, we have to remember that ibrutinib has been approved as a single agent in relapsed refractory CLL. However, idelalisib is being approved in combination with Rituxan, which really gives you the advantage that may reduce the lymphocytosis phenomenon that is being classically seen with these drugs. However, I think we see more and more that the beneficial use of BCR inhibitor, ibrutinib or idelalisib, before starting monoclonal antibody, mainly due to the fact that they dramatically reduce the infusion reaction that monoclonal antibodies may have in the practice. So I think, once again, we are learning as we go. I think in the future we're going to start to really see multiple combinations with several drugs with different mechanisms of action, but I will really anticipate that very likely the first drug to be used will be a BCR inhibitor followed by a monoclonal antibody, so the infusion reaction can be decreased and the beneficial or the decrease of this lymphocytosis phenomenon that is not really a concern between people who has experienced academic institution, rather is some concern about the community oncologists, something can be easily treated.
At present, very little is known about the optimal combinations or optimal sequencing of novel agents with each other or with antibodies. There is some evidence that if you start the novel agent ibrutinib or idelalisib prior to initiation of an antibody, there may be a decrease in infusion reactions associated with the administration of that antibody, and that could be an advantage. But from a clinical outcome standpoint, in terms of response rates and progression-free survival, we don't know if sequencing of the novel agent and the antibody matters. In fact, we don't actually know if adding the antibody to the novel agent results in a significant difference. Most of the ibrutinib data to date looks pretty similar between ibrutinib single agent, ibrutinib in combination with an antibody, and even ibrutinib in combination with BR, although the follow-up data on that trial are still short. So I think it remains an open question whether adding an antibody to these agents is necessary or beneficial. Sequencing of the novel agents is another potential problem. Currently, many patients are getting ibrutinib first, and there's an assumption that they'll be able to be rescued later with one of the other agents, or even chemoimmunotherapy. We have absolutely no data on our ability to rescue these patients. There are two reports, one from Ohio State and one from MD Anderson, suggesting that they respond poorly to any type of additional therapy, have a relatively high rate of Richter's transformation, and a relatively short survival. So this is concerning for widespread use of ibrutinib until we find ways to salvage people. Now, it is possible that as ibrutinib moves earlier in the disease course, patients who relapse after ibrutinib will not be so refractory to other therapy as they have been from the earlier studies. But we don't know that yet. We don't know that chemoimmunotherapy will work after novel agents, and we don't know that PI3 kinase inhibition will work after ibrutinib. So this remains a major unknown about our use of these drugs that we need intensive study to clarify.
We've done a trial in terms of combining the small molecule inhibitors, so that's one big area of active research, and we need data. Idelalisib was approved in combination with rituximab because the trial that was done was idela plus rituximab versus rituximab plus placebo, and that trial was positive, and so it was approved with rituximab. And there was another trial that was recently reported which replaced the rituximab for ofatumumab, and that showed improvement in outcomes for patients who got that combination versus the ofatumumab monotherapy. Now, IDELA is different in the sense that it was originally studied and developed and approved in combination with a CD20 antibody. And that's in contrast to ibrutinib, which was approved as monotherapy. With IDELA, there is clearly improved outcomes when you combine the small molecule inhibitor with the CD20 antibody versus CD20 antibody monotherapy. The trial with IDELA monotherapy versus the combination hasn't been done. But my impression of the monotherapy activity that we've seen with IDELA is perhaps the CD20 antibody does add to the activity of that drug. For ibrutinib, it's less clear. So ibrutinib, we are in the middle or towards the end of enrollment of a clinical trial of ibrutinib plus or minus, with or without rituximab, because we don't know if rituximab adds to the benefit that's seen with ibrutinib. And so it's important for us to generate the data and to really determine if you need a CD20 antibody combined with ibrutinib as a treatment strategy. So in terms of the chemoimmunotherapy regimens and the integration of CD20 antibodies in treatment, the trials that have been done are similar in terms of what was done with rituximab and ofatumumab. So chlorambucil has been combined with rituximab, chlorambucil has been combined with ofatumumab. Those trials comparing those combinations to chlorambucil monotherapy were clearly positive, showing improvement in progression-free survival with a combination. The complement-1 study was chlorambucil plus ofatumumab versus chlorambucil monotherapy, and that data has been published recently and is clearly positive in terms of progression-free survival. Not yet an appreciation of overall survival improvement between in comparison of those two arms. As I mentioned, chlorambucil rituximab has been compared to chlorambucil monotherapy. That comparison was also positive. The FCR regimen was compared to FC, and that was done in the frontline setting in a large randomized German CLL study group trial. That showed improvement in overall survival for FCR compared to FC. That same regimen was studied in salvage. That trial was referred to as the REACH trial. That trial was also positive, showing improvement in progression-free survival with FCR in the relapsed setting compared to FC. And now we have this trial that you're referring to as the complement-2, which is a comparison of FC versus FC ofatumumab. And the details that I know about that trial is that it was a positive trial showing improvement in progression-free survival, as I would expect with the combination of fludarabine cyclophosphamide and ofatumumab versus fludarabine cyclophosphamide. The response rates were similar to what we've reported with our chemoimmunotherapy regimens in the salvage setting, our FCR-based treatment strategies, and the progression-free survival is consistent with what I would expect for a CD20 FC combination. So that trial, the complement-2 trial, to me confirms activity and tolerability of that combination. For the US, it may be less relevant because of the small molecule inhibitors and because of the fact that patients are going on to a small molecule inhibitor as a salvage therapy. It's probably more globally relevant, more globally meaning across the world where they don't have, there's many countries who don't have these small molecule inhibitors available for treatment either in the front line or even in the salvage, and they are in the situation where we were before we had those in terms of, figuring out what the most appropriate first-line therapy is, assessing the first remission duration, and moving on to more effective combinations as a salvage therapy, chemoimmunotherapy combinations as a salvage therapy, because they don't have these small molecule inhibitors as treatment options.